Dear participants, my name is Dr. Julia Zając, and I have a pleasure to welcome you at another seminar under EuroBloodNet First Day Webinar Program. And I would like to thank you all for participating today, especially under current circumstances with COVID-19. We really appreciate it. Please mute all of the microphones and switch off your cameras because it will help us to maintain better streaming quality. And also, I would like to encourage you to ask any questions you may have during the presentation in the chat section. Please welcome with me Professor Graça Porto, who will speak today about challenges in the management of the HFE-related hemochromatosis. Professor Graça Porto is a hematologist and chief consultant at Santo Antonio Hospital in Porto. And among her many scientific achievements, she publishes European practice guidelines for diagnosis of hematological disorders. And also, she's currently a coordinator for disorders of iron metabolism in EuroBloodNet. So please, Professor Graça Porto, microphone is yours.
Okay, thank you very much for this introduction. I will start by briefly exposing my disclosures. I worked as advisor for Vifor Silence Therapeutics and as invited speaker for Novartis. So now coming to the topic. So the objective of this seminar is to assure that you all understand well the etiopathogenesis of HFE-related hemochromatosis, that you will have no doubts regarding how to act in practice to suspect, diagnose and treat the disease, and finally to feed the discussion around the best screening strategies for disease prevention. As an introduction, I will just very briefly recall you how the systemic iron homeostasis is strictly maintained through a very efficient recycling system. The amount of iron needed per day for the red blood cell production in the bone marrow is available in the circulating pool of transferrin-bound iron, which is mostly derived from recycling macrophages and a very small part from iron absorption by the duodenum to compensate the small iron losses. The liver is the organ that orchestrates all this movement of iron across compartments because it senses the iron needs from erythropoiesis and the iron excess in circulation. And then, through the production of hepcidin, it signals macrophages and epithelial cells in order to export or retain their intracellular iron. So the master regulator of iron homeostasis is indeed hepcidin, a small peptide produced by the hepatocytes that binds to ferroportin, the only known iron exporter, promoting its degradation and therefore limiting the entry of iron into circulation. Hepcidin synthesis is downregulated by signals of iron deficiency, hypoxia, or increased erythroid activity, and in all these cases favoring the export of iron into circulating in the circulation by ferroportin. On the contrary, inflammation or iron overload will be upregulated, thus retaining the iron in macrophages and limiting iron absorption on the duodenum. In hereditary hemochromatosis, this system fails. Hepcidin is not appropriately stimulated, and then iron absorption is increased. Iron is not retained in macrophages in spite of increased amounts of iron in circulation, and mostly is bound to transferrin in circulation. But as the transferrin saturation increases, iron appears also in the form of non-transferrin bound iron, NTBI, that will accumulate in several tissues, mainly in the liver, with consequent oxidative damage. One of the crucial points in iron homeostasis and that fails in hemochromatosis is the way how the liver senses iron toxicity. It has been recently shown that the sensing mechanism operates at the level of the liver sinusoidal cells and through NRF2, that is an important transcription factor involved in the response to oxidative stress, that stimulates, in response to iron, it stimulates the production of BMP6 that in turn will signal hepcidin synthesis through the SMAD pathway, involving a complex pathway, this pathway involving the so-called hemochromatosis proteins. One of these proteins, HFE, is the one whose deficiency is responsible for the most common form of hemochromatosis, and therefore its designation as HFE-related hemochromatosis. Of course, other proteins in this complex may also cause hemochromatosis, but those are very rare forms that will not be addressed today in this presentation, but will be described in detail in the next webinar by Professor Girelli. Do not miss that seminar. In summary, we can define hemochromatosis as a group of genetic disorders of iron overload, which can potentially result in impaired organ structure and function in the liver. The definition also includes genesis, that is the deficiency of hepcidin signaling. Why is this important? Because it creates one of the major criteria to suspect of hemochromatosis, that is an increase in transferrin saturation. And this is the unifying feature of all forms of hereditary hemochromatosis. So diagnosis is simple. First, we must suspect, and that is achieved with simple biochemical markers of iron overload. In hemochromatosis, transferrin saturation is typically above 50% in women and 60% in men, and serum ferritin will be high, reflecting increased iron stores. I deliberately did not show cutoff values here for ferritin because in reality there are no absolute normal values for ferritin, but rather expected values in a high number of different conditions and depending on sex, age, lifestyle habits such as alcohol consumption or high-fat diets. Another important issue with ferritin, with this marker, is that it is highly unspecific. It is an inflammatory protein, and it is increased in many clinical situations, such as listed here, of which I would stress the most common, which are liver steatosis and chronic alcohol intake. So ferritin should never be used alone as a marker of iron overload. I think we hematologists have a mission. We have to insist a lot with the correct use of the terms hyperferritinemia, iron overload, and hemochromatosis that unfortunately are many times confused. I believe most of us receive a lot of referrals for suspected hemochromatosis based on ferritin alone, and only a small part will correspond to a true suspicion of hemochromatosis. But one of the reasons for that is because of the great and easy availability of genetic testing that many people are using as a first-line test, as an exclusion test. but that is not the recommended procedure. HFE genotyping is indeed recommended as a confirmatory test in face of a suspicion of this particular form of hereditary hemochromatosis, that is the HFE-related hemochromatosis associated with homozygosity for the C28Y variant. This variant consists of it's I don't know if you can see, because I see here I don't know if you are seeing this picture of the molecule, but is a change of cysteine to tyrosine in position 2A2. That is the place of binding of the alpha-3 domain of this MHC molecule to the beta-2 microglobulin. This binding is essential for the protein to be expressed at cell surface. Therefore, people homozygous for the C28Y variant will not express HFE at cell surface, and the cell will not sense iron overload. Apart from the C28Y mutation or variant, only very rare mutations in HFE will have this same effect. It should be noted that this genotype supports the diagnosis of HFE-related hemochromatosis, but the formal diagnosis requires demonstration of increased hepatic iron stores. That's part of the definition. I cannot escape mentioning one of the most confused situations in the genetic diagnosis of hemochromatosis. That is when an individual with biochemical evidence of iron overload is found to be a compound heterozygous for C28Y and H63D, which is a very common normal polymorphism, and that does not affect the expression of HFE at cell surface. For some time, these individuals were classified as hemochromatosis, and some people still do it, but there is now sufficient evidence showing that individuals with this genotype are not at risk of developing a severe iron overload like the homozygotes, but are only at risk of developing a mild to moderate iron overload when associated with other acquired conditions such as alcohol consumption, fatty liver, or this metabolic syndrome. The importance of not putting the label of hemochromatosis in these cases is because it obliges to look for other comorbidities and to correct them. The guidelines for the molecular diagnosis of hemochromatosis also offer a set of recommendations how to report results of HFE genotyping regarding other genotypes. I am not going to describe in detail step by step, but I would like to highlight some points in this table that you can consult in this reference. What I would like to highlight is first that the only genotype, this is divided in two types of interpretation, if it is asked for as a diagnostic test or if it is asked as a predictive test. And only the homozygous C28Y is at risk, is compatible with the diagnosis and is at risk of developing severe iron overload. All other genotypes involving H63D or heterozygous for C28Y, we may say that they exclude the diagnosis of the most common form of HFE-related hemochromatosis. And in terms of risk, when it's used as a predictive testing in family screening, the carriers of these genotypes are not at increased risk. The only genotype that we can say that has a low risk if associated with other conditions, is the compound heterozygous. Another thing to stress here is that in the consensus meeting that we had to publish this guideline, we all agreed that we should not use testing of the S65C variant for the diagnosis of hemochromatosis. Many people, when request testing, they ask for this variant. This variant is not recommended for diagnosis purposes, and if detected as an incidental finding, it should not be reported but treated as a no variant detected. So we have to exclude the idea that this variant is associated with hemochromatosis. Once a diagnosis of HFE-related hemochromatosis is established, family screening should be implemented. Because the prevalence of individuals at risk to develop morbidity is increased among first-degree relatives of index cases, that are the homozygotes, their identification through predictive testing is appropriate. But please remember that we are testing adult asymptomatic individuals, and that must be undertaken with appropriate counseling, addressing the pros and cons of testing, as well as the possible clinical consequences related to test results. These are general rules for predictive testing. In terms of management of patients with C2H1 homozygosity, if they have a normal ferritin, this could happen in young people screened in the family context, for example, they should be monitored once a year to follow the eventual increase in iron overload. In the case of increased ferritin, there is a formal indication to treat by phlebotomies. This pathway from here will always end in indication for treatment. Okay. So if the serum ferritin is greater than 1,000 micrograms or nanograms per ml or micrograms per liter, the patients should be assessed for the presence of liver cirrhosis, because this is one criterion of risk for cirrhosis and fibrosis and cirrhosis. Okay, so this can be done either by biopsy, liver biopsy, or elastometry, the fibroscan. In any case, patients have to be assessed for the possibility of related morbidities such as diabetes, hypogonadism, cardiopathy, or arthropathy, but this is part of the normal medical workup. So, some of you may ask if we need to quantify liver iron concentration, LIC, for the diagnosis of hemochromatosis. And as you saw in the previous workup algorithm, it is not necessary for the diagnosis of HFE-related hemochromatosis when the genetic test confirms C2H1 homozygosity. But more and more commonly, we are using LIC determinations for various purposes. First, it is important to assess the severity of iron overload and so define a prognosis. Prognosis and the chance to have a cirrhosis or developing a hepatocarcinoma depends on the amount of iron accumulated in liver. So classifying the severity of iron overload is important. And this can be done either by liver biopsy, in this case with the advantage of assessing also the liver histology to diagnose liver cirrhosis, or by magnetic resonance imaging that is eventually more accurate in terms of quantification, but does not detect liver fibrosis. A leak greater than 300 micromoles per gram is generally accepted as a general criteria of severe iron overload, typically found in patients with hereditary hemochromatosis who are diagnosed after the 40 years. Finally, it will be before the differential diagnosis, I think it is important also to measure leak, liver iron concentration, to predict total body iron stores, because when we calculate the amount of iron accumulated in the liver is directly proportional to the amount of iron that will be removed by phlebotomy. This parameter here, total body iron stores in grams, is the amount of iron that we will remove by phlebotomy treatment, and we can predict by measuring the iron concentration in liver and pancreas. And this is important for patients because it will predict the time of treatment that they will have, and so they can program also their lives. So now, finally, yes, it will be more important for the differential diagnosis of hemochromatosis when HFE genotyping does not confirm C2A2I homozygosity. Because in this case, we have to decide if there is an indication or not to search for rare mutations in HFE or in other genes, and this will be done only in the case where we demonstrate a severe liver iron overload. In this context, I would like to call your attention for the advantage of MRI, not only to estimate leak, but also to give a picture of iron distribution in other organs. This is important, for instance, in the differential diagnosis with Ferritin disease, a distinct clinical situation due to defect in the Ferritin gene, where iron accumulates preferentially in the spleen, also accumulates in the liver, but it's more accumulates more in the spleen. So the pattern that we see in the MRI is the opposite of the classical. Now treatment. The standard treatment of hemochromatosis is the phlebotomy treatment. It consists of two phases. One intensive phase of weekly phlebotomies of about 400 to 500 mL, aimed to deplete maintenance treatment, usually with phlebotomies every 3 or 4 months, with the objective of preventing iron reaccumulation. The intensive treatment should be maintained until serum ferritin reaches 50 nanograms per ml. Regarding the maintenance, there is no formally established optimal target values for ferritin, but the most consensual values so far are to maintain serum ferritin between 50 and 100 nanograms per ml. In this graph, I am showing you the global change of transferrin saturation and serum ferritin in a cohort of hemochromatosis patients from our clinic during intensive treatment, that is on the left part of the graphs, and during maintenance treatment on the right part of the graph. And what is clear in this message is that while we are able to maintain serum ferritin at low levels during maintenance treatment, that is not true for transferrin saturation, and many patients will return to the basal high levels in spite of treatment. There is, however, no evidence so far that these patients reaccumulate toxic iron in tissues. Therefore, there is no formal recommendation to try to lower transferrin saturation levels as long as ferritin is within the correct limits of 50 to 100. In terms of hematological parameters, it is interesting to note that the increased mean corpuscular volume, that this is a characteristic of these patients in iron overload condition, and it is due to the higher iron availability for erythropoiesis, and it is partially corrected after treatment. And hemoglobin levels can even stabilize at higher levels after treatment. The reason for this is still under investigation. In the last part of this talk, I discuss with you one issue that is now on the top of the agenda of many patients' associations and federations, such as IFAP, which is the question of population screening. Should we screen the population at large for this disease that is many times referred as the most common genetic disorder in European populations and whose consequences can be preventable? Well, definitely a European-wide genetic screening of the population is not recommended. And this is for two reasons. First, the allele frequency of the mutation or the variant, C282I variant, is highly variable among different regions, and we cannot estimate one global expected frequency. As examples that I'm giving here, while we expect a very high frequency of homozygous in countries like Ireland or Scandinavian countries, the same is not true in other countries, like in Romania, for instance, where it is a rare disease, a rare condition. Variations can occur even within the same country. For instance, in Portugal, the expected number of homozygotes is very high in the north, but not in the south of the country. And this geographical gradient, north-south, is also occurring in many other countries like Spain, France, or Italy. So it's difficult to promote a global policy for genetic screening. The second and strongest argument against genetic population screening is the fact that penetrance of disease is expected to be low. Therefore, most of asymptomatic homozygous will probably never develop the disease, and in that case, they should not be put a disease label. So, the best strategy for prevention will be to enhance case detection through biochemical screening. What we have learned with this recent work from the group of Rennes is how the clinical picture of hemochromatosis has changed for the last years since we have introduced diagnostic genetic testing and family screening. I call your attention for the fall in the curve of severe liver fibrosis in orange, but what is striking is that the average age at diagnosis is maintained around the 40 years. This means that we are not detecting earlier, but instead we are detecting more cases with less severe expression. So but we still have around 20% of, even with all these measures and all these easy screening and easy early diagnosis, we still have 20% of patients, male patients with severe fibrosis. So the question we may pose is, can we further decrease this 20% frequency of homozygous males with severe liver fibrosis? Put in other words, how many years before could these patients have been detected? And the answer may come from this large longitudinal study with 24 years follow-up of more than 600 cases in Australia, with ages ranging from 10 to almost 90 years. And where the authors estimated the rate of iron accumulation with age and concluded that the mean age of homozygotes with severe hepatic iron overload would be approximately 21 years after the hepatic iron stores begin to increase, both in men and women. So when ferritin starts to increase. So this means that eventually the ideal average age for diagnosis should be not at 40 years, but rather at 20 years. Is this true? Well, we had the opportunity to follow for 20 years 3 siblings that were diagnosed by chance in childhood and were systematically checked to assess the rate of iron accumulation. And indeed, what we observed is that at the age of 18 to 20 years, they already had signs of iron overload, so they were properly treated at this age. So, in conclusion, we must be aware that the clinical spectrum of HFE-related hemochromatosis varies from a simple genetic predisposition to a very severe disease and early death, and that today we have the means to effectively prevent the progression of disease if this is detected and treated early. So, our take-home message is that the best strategies to prevent the severe clinical consequences of HFE-related hemochromatosis are to increase awareness, particularly among general practitioners, in order to enhance early case detection, perform a correct diagnosis, and implement family screening in adult first-degree relatives. We also advocate the population biochemical screening at younger ages, that is between 18 and 20 years, with confirmatory genetic testing as a long-term strategy to prevent the occurrence of severe liver disease. And this is my message, and thank you. And now I am open to respond to your questions.
Thank you, Professor Porto, for this excellent presentation. And now we have time for discussion. And as I already can see, we have first 3 questions from the audience.
Okay. This is a good question, because in the definition of hemochromatosis, there should be iron overload. So in this case, we cannot classify as a hemochromatosis case, although he is a homozygous. There are several suggestions, either to call stage 0 or preclinical hemochromatosis, but we cannot classify as a hemochromatosis patient. Perhaps the most widely accepted is hemochromatosis stage 0. So in the relatives of compounds, we are not advising genetic predictive testing in these family members, because they are heterozygous. And in general, the genetic screening in heterozygous, the genetic screening of family members of heterozygous is not recommended, because it would, in the end, it would be the equivalent of having a screening of the general population, because it would increase a lot the number of cases. So we do not recommend genetic screening, but we may recommend biochemical screening, because they are at risk of slight increase in iron overload if they have other associated conditions. So other people may be in the same conditions, and so we can advise biochemical screening of the family members. We don't have evidence in our population, in our European population. The only study that analyzed long-term follow-ups of subjects that are homozygotes and not expressing was again in Australia, the Health Iron study, and they follow these subjects, and they reached the conclusion that if serum ferritin does not increase until 55 years, it will probably not increase anymore. So we can stop the follow-up at 55 years. If they do not express any sign of iron overload.
Thank you, Professor Porto, for answering all of these important questions. And thank you so much again for participating in First Day webinars. It was truly an honor for us to have you as a guest speaker.
Okay, thank you. Thank you very much for this opportunity. Okay, and have a nice week.
Before we go, I would like to invite you also for other First Day webinars. You can check the program at our website. And of course, please subscribe to our newsletter where you can read about our actions we are involved in. And of course, follow us on Twitter, LinkedIn, and Facebook. And also check other publicly available webinars on our EuroBloodNet's Edu YouTube channel. Thank you very much and see you next time.